Hello everyone, this is Professor DePaulo. Today I'm going to be talking about the introduction to abnormal psychology, past and present. So abnormal psychology is the scientific study of abnormal behavior. Behavior may seem odd or eccentric, but that doesn't necessarily make it abnormal. You hear the word abnormal thrown around way too much these days. For a behavior to be considered abnormal, you must meet the criteria of having the 4Ds. You want to have as many of these 4Ds as possible. The more you have, the more likely the behavior is going to be considered abnormal. First one is deviance, which is bizarre or different behavior. By itself, it's just odd. Combined with the other things, it pushes towards a direction of abnormality. So deviance, strange, unusual, bizarre behavior. Distress, it causes, it's very upsetting to the person. The person wants to stop it. The person is very upset by their deviant behavior. Dysfunction interferes in the person's ability to conduct their everyday life activities. So that includes going to a job, having success on the job, keeping a job, having successful relationships, being a good parent, or resolving family conflict, things like this, where we usually have to engage in these behaviors as part of daily living. And the person that is experiencing dysfunction is not successfully navigating these basic responsibilities, if you want to call them that. And the last one is danger. And danger is not too common with abnormal behavior, with mental illness, but it can occur in a smaller percentage of people where there's a risk of harm to themselves or others. For example, suicide. In more extreme cases, homicide with your antisocial personality disorders, your psychopaths, could be cutting oneself in the case of borderline personality disorder. It could be someone that's very aggressive and maybe has poor impulse control, whether that be from a manic state in a bipolar disorder, or it could be from psychosis, which results from both extreme mania and more commonly from schizophrenia. But this is rare. Most people with mental illnesses, including schizophrenia, are not inherent dangers. There is a small percentage that are, and these people need to be restrained, and these people need to be under surveillance. But that's the more extreme cases. Most of the cases, even with schizophrenics, these people are distressed, they're dysfunctional, they're very, very odd, but they're not necessarily dangerous to themselves or to other people. Yet the general public is kind of afraid of them because they think of schizophrenics as being inherently odd and possibly dangerous, which is not necessarily true. Thomas Zatz, who was a major part of the anti-psychiatry movement, criticized the criteria in the DSM for judging or diagnosing people as having a mental illness. And he says that basically there's no organic evidence, there's no biological evidence that indicates whether someone has depression or someone has schizophrenia or bipolar disorder, etc. And therefore, societies are labeling people as being mentally ill in order to control these people that threaten the social order or sort of the way they expect society to behave. And he gets some pushback. I mean, he gets a lot of pushback from people stating that the labeling is really only to oppress people. However, you have to look at the way he examines the role of mental illness in society and kind of have a little bit of concern with the impact of labeling on people's behaviors, because a label creates a self-fulfilling prophecy where the patient diagnosed with the particular mental illness will go out and look for more confirming evidence to justify that illness, and it becomes a self-fulfilling prophecy. You look for it, you find it, and therefore that confirms I'm sick, I have this disorder. And that can lead to, comorbid depression, comorbid anxiety, feelings of helplessness, people becoming more reclusive, etc. in some cases. And the impact of the diagnosis can have overall a negative, uh, it can have a negative role, play a negative role in people's outcome in dealing with the disorder they have. And you see this with the Rosenhan study that I had you guys read. So Zatz gets a lot of criticism because people think, well, he's just really gone too far saying that society is labeling people to control them. But I think the point he makes is that labeling can have negative impact on society. Diagnosing can have a negative impact on society. And we really don't have any objective criteria to diagnose a mental illness. We don't have an objective criteria for depression. We know it's low levels of serotonin and norepinephrine, but there's no way to really measure that. A blood test doesn't measure that. A urine test doesn't measure that. So there's a lot, it's a lot different than looking at a physical illness, which can be diagnosed with a physical test. A mental illness is much more complex, and it's based on interpretations and symptoms that have been laid out in the DSM. So once the diagnosis is made, whether that diagnosis is harmful or not, in some cases it is, in some cases it's not as harmful, clinicians talk about treatment. And treatment is a procedure designed to change the abnormal behavior into a more normal behavior. And we like to talk about treatment in terms of cure. I'm cured from cancer. Well, that's great. That's wonderful. But can you really be cured from a mental illness? And in the case of mental illness, we don't talk about cure. We talk about treatment. And you once again see this in the Rosenhan study, where patients are diagnosed with schizophrenia, and then when they're, so-called cured, they get the diagnosis of schizophrenia in remission. So there's an issue with the idea of like a total cure. And so I don't like to use that word in terms of mental illness because there tends to be a cyclical pattern of being diagnosed, of having an illness and then getting better and getting worse and then getting better again. It tends to be up and down. You could be stable for many, many years, and then some stressful life event can trigger a relapse of the disorder. This is all possible. So the idea of cure is a little bit tricky with regard to mental illness. So can you be treated? Can you be stabilized? Can you improve? Of course. Can you be 100% cured? Yeah, I don't like to use that word. I like to use the word, I'm doing well, I've been treated, I'm not having any problems right now. But I think, when you talk about cure, people feel like, oh, I feel so much better. I don't need to go back for therapy. I don't need to take my medication anymore. And so then they stop because they feel like they're better, they're cured. And then slowly but gradually the symptoms come back, and then they get to a point where they're in a panic and they're saying, something's really wrong, I'm getting worse, I don't know what's going on, I have to go back into treatment. And so keeping someone in treatment for a prolonged period of time is going to lead to a long-term better outcome in most cases, given that, the severity of the illness. Saying you're cured or thinking you're cured is going to lead to pretty much stopping the treatment, which then can lead to relapse in the future. So cure has kind of a loaded and negative tone to it. In terms of treatment, there are three essential features. You have a sufferer, who's the patient or the client. In psychoanalysis, they call the people that get psychoanalysis patients. In all other forms of therapy, they're now referring to these people getting treatment as clients. In the hospital, you're a patient. In the outpatient, you're a client. So you might think of it as kind of an arbitrary cutoff there between patient and client. But client is preferred over patient in terms of psychological treatment. So that sufferer, the client, is going to a clinician who is a healer. and they are trained and they have expertise, whether it be a social worker, a psychologist, a psychiatrist, a psychiatric nurse practitioner, etc. And then there's a series of contacts between the healer and the sufferer in which change is gradually introduced. In the case of cognitive behavioral therapy, that change could be 12 to 16 weeks. In the case of traditional psychoanalysis, that change could take years. So it really depends on the type of modality you're going for, what your goals are, how severe the mental illness is, and how long you've had it. 12 to 16 weeks is generally the minimum. If you're doing a short course of CBT, cognitive behavioral therapy, even a short course of DBT, dialectical behavioral therapy, where you're changing a behavior and you're changing cognitions, and you're having a flare-up of whatever depression or anxiety in the most cases that you need to treat, or even in the case of DBT, substance abuse. But most of the time, treatment's going to last longer than 12 to 16 weeks. Because if you feel a little better after 12 weeks and you stop the treatment, once again, you get a stressor in your life, you can't adequately cope with it, it then leads to a relapse. So treatment generally is long-term. In the case of psychoanalysis, it's really long-term. It's like many years. I'm not just saying that treatment has to be that long. But, if you expect like 8 to 12 weeks of therapy and then you're going to be 100% better and never relapse, that's kind of a difficult expectation to have. Now, in any given year, as many as 30% of adults and 19% of children and adolescents display serious psychological disturbances and need treatment. That's a huge portion of the population. It's a seriously big portion. Now, these are people that are not getting the treatment. Only a small fraction of this group is getting clinical treatment. Most people with diagnosable psychiatric conditions in this country are not going for treatment. And obviously, treatment is more common with women than men. So you see women getting more psychological treatments, not because they have inherently greater psychological problems. That's not the case at all. It's because they are more proactive to seek treatment. Whereas men will, avoid treatment for the most part. We're talking about on average. I'm not talking about every single person. So about on average, overall, men avoid treatment. Men self-medicate rather than seek treatment. So there are clear gender differences here. But there's also a large portion of the population, especially among people of lower socioeconomic status, that are not getting the treatment that they need. They're not getting diagnosed. They're not getting treated. They're not seeing anyone. They're just struggling with their psychiatric conditions, psychological conditions, and they're just kind of trying to do the best they can, but a lot of times they're suffering. And they're having, problems with deviant behavior. It's causing distress. It's causing dysfunction. In some cases, it does cause danger, and yet they're still not seeking treatment. Is this the fault of modern society? Well, society plays a big role. Going back a few decades, the stigma associated with mental illness, although it's getting better, it's still not good enough. It's still not there. We are not, at the current moment, in open society with regard to dealing with mental illness. We are very open with our physical ailments. It's no secret if someone has cancer, it's not that they're trying to keep it a secret, really. They let people know, and you feel bad, feel sorry for them and that they're suffering, and you understand their pain. But if someone came out and said, I'm having severely debilitating depression, I want to kill myself, right away there's like silence. The general public is kind of like, what do I say now? I understand cancer. I understand the pain of that. I understand the suffering with cancer. But do I really understand the suffering with depression? Some people may be like, oh, it's depression, deal with it. That's what I would do. I would deal with it. I deal with my problems. You're not. You're making excuses. So that's one sentiment. The other sentiment is over-exaggerating things. Another sentiment is, I don't know what to say, so I'm going to say nothing. I'm just going to ignore it like the person never said anything about depression. I'll just pretend it doesn't exist. So there's a vastly different sort of conversation revolving around physical illness compared to mental illness. It's getting better. It's getting better than it was, 20, 30 years ago, but it's not there yet. There's still issues. There shouldn't be silence. There shouldn't be, avoiding the person that's depressed or anxious. It should be, wow, that's a lot of, I understand your pain. I had anxiety for the longest time, and it wrecked my life. Instead of just saying, oh my God, should I say anything or not? This is, I'm very uncomfortable listening to someone tell me about their mental problems. We all have mental problems. Some people to a greater degree than others. But every single adult and many, many children in this country have had phases where things haven't gone right and they were maybe headed in the direction of a diagnosis. Not saying that everyone had a diagnosable mental condition. I'm saying that people hit speed bumps in their lives and they can easily go off the rails. Some people do and some people don't. Some people fall apart and others are able to cope better when it comes to dealing with significant stressors in their lives, and we all have these significant stressors. And I think some people just, they have hard times. They've been hit with a lot of negative things, and they have a hard time coping. So is it the fault of modern society? Yes, to a degree. We're working on it. We're getting people educated about mental illness, and eventually this is going to improve. I think it is improving, just very slowly. Can we get to a point where we're as open about mental illness as we are with physical illness? I don't know. I'm not sure if we ever get there. If we get there, it might be way in the future. Maybe when we find out that mental illness is caused by certain gene combinations and we can then tailor a treatment to the particular precursor genes that you have. So like, gene therapy. And with the establishment of gene therapy, maybe people start seeing mental illness as a genetic condition, which it is. Everything's a genetic condition, right? I mean, this whole nature-nurture debate. Everything is caused by some combinations of genes and environment. But once we get to like possibly treating the genetic precursors for a particular mental illness, maybe mental illness then becomes equivalent to physical illness. I don't know. That's possible. I mean, that's happening in the future. We're going to have these genetic treatments tailored to individuals. That's the future of medicine. Treating people individually based on their genes, predicting that they're going to have some illness down the road, years ahead of time, and then treating it and preventing that illness from occurring. Maybe it'll get to that point where mental illness starts to be on par with physical illness. I don't know. We are making improvements, but we're not there yet. So part of the theme of this course is to see the equivalence of physical illness and mental illness, and to get rid of the stigma, and to be open about talking about mental illness. Because there's no reason not to. Mental illness costs a tremendous amount of money. So it's associated with chronic diseases such as cardiovascular disease, diabetes, obesity, asthma, epilepsy, and cancer. There's a lot of times you have a physical illness and then it triggers a mental illness. So cancer definitely triggers anxiety, definitely triggers depression. And, so successfully treating cancer requires treating the physical cancer and treating the psychological burden that comes with that diagnosis. Mental illness is also associated with lower use of medical care, reduced adherence to treatment therapies for chronic diseases, and higher risk of adverse health outcomes. And that makes sense. People with severe anxiety or depression, given that those are the most common mental illnesses that are diagnosed, they're less likely to go seek out treatments. A lot of times they avoid. Someone that has really strong anxiety will avoid doctor's offices. And sometimes they'll constantly go to doctor's offices. So there's a wide pattern there. Uh, but as a whole, these people are not accessing medical care as much as they should. And that leads to higher risks of adverse health outcomes. And you see this also in populations of lower socioeconomic status, where these individuals don't seek medical care. They don't seek psychological or psychiatric care. And they end up with more severe health outcomes. Many people suffer from more than one mental disorder at a given time. This is called comorbidity. Nearly half of those with mental illness meet the criteria for 2 or more disorders. So that's comorbidity. So the most common comorbidity in terms of abnormal psychology or clinical psychology is depression and anxiety. They very often occur together. Mental disorders are one of the 5 most costly conditions going back from the last data point that I have, which is the mid-2000s, with expenditures at about $57.5 billion, and that number is going up. So it's costing our country a ton of money. It's very expensive. And the fact that people are not getting treatment is raising the cost because it's leading to a longer term, more costly condition. And there's also a huge problem in this country with substance use and abuse. And that is often correlated with a mental illness. So you have a mental illness and you're trying to self-medicate, you start using drugs. And now you have both a mental illness and a drug problem that both have to be treated, and sometimes they have to be treated differently. So going back to ancient times, going back to 5000 BC, there was a lot different treatment for mental illness than there is currently, obviously. We all know this. Present day treatments, though, can sometimes resemble past treatments. So the idea of lobotomy, which occurred in the early part of the 20th century, is not that radically different from, say, trephination, which occurred thousands of years ago. So ancient societies, I'm saying going back to 5000 BC, thought that there were evil spirits that were the results of, that were causing mental illness. And the 2 most common treatments in ancient times were trephination, which is drilling a hole in the skull. So with trephination, you drill a hole in the skull and the evil spirits leak out. How convenient. I'm just going to drill a hole in my skull and the evil spirits will all go away. And exorcism. Obviously, exorcism was used more during the Middle Ages, more during a time when the church had a greater influence, and that is basically expelling through religious principles, expelling, satanic forces, demons from the person's body, and that would cure the mental illness. So these are 2 radical approaches to treating a diagnosable mental condition. There was no SSRI drugs, there were no antipsychotics going back thousands of years ago, or even 100 years ago. So people were just desperate to figure out what to do with severely mentally ill people. And these are very extreme measures that obviously at the time sounded like good ideas. And exorcism can be still performed in modern day, but it's purely associated with the church, And this is not an approach to treat, you know, regular psychiatric conditions. So it's very controversial. Trephination obviously is not used today, except if you have increased intracranial pressure. Basically, you know, you have some kind of bleeding in the brain, and the pressure is building up in the brain that you have to drill a hole in the skull and ease the pressure. We don't really call that trephination, but and they're doing it for a medical reason, not for a psychiatric reason. That's the only thing analogous to trephination in modern society. So if we go back to ancient Greek and Roman views and treatments, so as I said before, going back thousands of years, all the way to 5000 BC, you had trephination, or drilling the hole in the skull, as the major treatment for mental illness. Fast forwarding to 500 BC through 500 AD, you had, significant Greek and Roman influences in terms of treatments of mental conditions, because these civilizations were thriving. And Hippocrates believed at the time that mental illness was caused by an imbalance in the four humors in the body: black bile, yellow bile, phlegm, and blood. So these four humors, or fluids, were out of control, they were imbalanced, and the goal was to rebalance them, and that would ease the psychiatric syndrome that the person had. It does make sense on some very primitive level that there is an imbalance. I mean, we talk about imbalance of neurotransmitters now as the cause of mental illness, or one of the causes. Hippocrates thought it was the imbalance of humors or fluids. So it's not drastically different than what we think now, but it's obviously not supported by any evidence. By the year 1400 AD, the demonological views of abnormality continued to decline. The church was becoming less influential in terms of treatment of mental illness. So exorcism was on its way out, and more, I guess, sort of human-based, uh, compassionate methods were introduced. For example, the German physician Johann Weyer believed that the mind was as susceptible to sickness as the body. And so that was a much more human-centric point of view compared to demons invading your body and basically causing you to act in a certain way that was deemed abnormal. And because exorcism was on the decline, the care of people with mental disorders continued to improve. Across Europe, asylums were started. Now, you may have thought of asylum as being having a negative connotation, that all these people were just basically forced into one building, basically, and the madness was out of control. But that wasn't the original intent of asylums. The original intent of asylums was to really care for people that were mentally ill and to have human interactions with these people instead of treating them like they were possessed by evil spirits. You can slowly nurture them back to health and have lots of positive interactions. The problem was with asylums, there were too many mentally ill people, and there were not enough asylums. So what happened was they became overcrowded. The staffs were big enough to care for all these people, and it kind of got out of control. And it became a really dark place to be, where, all kinds of, you know, all kinds of problems emerged due to neglect, basically. There were just too many people and not enough staff. And that was the problem. Although asylums were originally thought to have a positive connotation, we're going to interact with people, we're going to engage them, we're going to slowly nurture them back to health. It became just all these people in one particular room, horrible living conditions, no interactions with staff because there were just too many people. By the 1800s, the moral treatment came more into the fold, and this was led by Philippe Pinel from France and William Tuke from England. And they believed that moral guidance and humane and respectful treatment towards people with mental illness was the best way to improve people that were suffering, or to help suffering people get better. And this was the original intention of the asylums, the original purpose of the asylums. But the asylums became so overcrowded that it just wasn't working out. In the US, Benjamin Rush and Dorothea Dix were also primary proponents of the moral treatment. Benjamin Rush was considered the father of American psychiatry. However, once again, this critical reform of the asylums, noticing that the asylums were not working out the way they were intended to work out, and we need to change things, this idea of change didn't work out either. Because once again, there was no money, there was staff shortages, there was overcrowding. The asylum problem could not be fixed. No matter what people did to try to reform what was going on, it never worked out. There wasn't enough money and there was just too many people. Now, the big problem with the overcrowding was that there were no outpatient people that were being treated for mental illness. It's not like today where you have a mental illness, you take a medication or you go to therapy and then you go back home. You don't have to be put in the hospital. You don't have to be put in a long-term residential facility. I mean, some people are, but most people aren't. Well, back in the 18th, 19th century, there was no option for outpatient treatment. So everybody that was mentally ill had to go into the asylum. And it just wasn't working out. There were just too many people. So by the early years of the 20th century, the moral treatment just wasn't working out again. Whether you want to stop the asylums and put people in the hospital, the same problem arose, right? So whether you're in an asylum or you're in a psychiatric hospital, it didn't make a difference. There was just not enough time, not enough attention, not enough resources to really help people get better. So they were basically stuck in either the asylum or by the 20th century, they were moved into a psychiatric hospital and they just couldn't get out. They were just stuck there. And they could live their entire lives in an inpatient psychiatric facility and never be released. Now, there's been even problems with regard to mental illness in terms of immigration issues. In 2013, a Canadian woman was denied entry into the US because she had been hospitalized for depression in the previous year. So there's a controversy here is where do you draw the line? I mean, do you want to ban people with mental illness because they're going to use resources? They're going to need to go to the hospital, or they're going to need to take medication, and if they're not a U.S. citizen, do you deny them this? Obviously, they can go to the hospital. You cannot deny them treatment. But do you ban them from immigrating because of mental health issues, or is this discrimination? And immigration is a very controversial, very fought over topic, especially in today's current political climate, is how do you determine who should be allowed to immigrate here and be put on a green card and have a path towards citizenship, and who should not be allowed. And there's a lot of factors involved, but should mental illness be screened before you allow people, before you give someone a green card and put them on a path to citizenship? Do you want to screen them for mental illness? And that's controversial. So now that I talked a little bit about the problems in the past in terms of treatment of mental illness, starting with Trephination and Exorcism, which are very difficult techniques, and then proceeding into asylums and long-term hospitalization, which are also problematic in their own rights. By the 20th century, there was a bit more optimism in terms of treating the mentally ill. And this had to do with pharmacological treatments being developed. This had to do with the idea of outpatient psychotherapy. But there are two main perspectives within the modern way of treating people with psychiatric problems. And those two perspectives are the somatogenic perspective and the psychogenic perspective. The somatogenic perspective talks about physical or biological causes. The psychogenic perspective talks about psychological causes of mental illness. So this is your nature-nurture debate. And as always, I tend to be more of a nature person, but you'd be naive if you said everything was just nature or everything was nurture. We all know that there's a combination of both of these factors that lead to the development of mental illness and the progression of mental illness. So Emil Kraepelin argued that physical factors are responsible for mental dysfunction. So there is a link between physical issues and mental issues, right? So if someone has a physical illness, especially a chronic illness, that can be associated with a comorbid mental illness, like depression or anxiety. Those are the most common. So the link between the physical and the mental has been around for a long time, and that started the whole idea of somatization, which we'll talk about later in the course. There were established links, and there were some studies run with the Tuskegee syphilis project, which was absolutely horrible experiment that was run early 20th century, where they basically did not treat people with syphilis intentionally. And they wanted to see what was going to happen if we don't treat syphilis. Would it lead to other issues, other medical concerns, other psychological concerns? And this human experimentation was really a dark era within psychology or within science in general. It wasn't specifically psychology, but within the medical field, human experimentation was just awful. Whether it was done in Nazi Germany, whether it was done here in the U.S., it was done here in the U.S., many times. Whether it be Tuskegee syphilis, or whether it be the Willowbrook hepatitis project, there were, I could even put the Milgram study in there and the Stanford prison experiment in there, which are psychological studies that were just absolutely awful. And I think very unethical, that could never be done today. Maybe it doesn't carry the same weight as Tuskegee syphilis, but nevertheless, it was extremely problematic. So there was a lot of research at the early part of the 20th century in terms of, can we come up with biological treatments for mental illness, knowing that the physical and the mental are connected. And these were not effective until the middle of the 20th century, or around the 1950s, 1960s, where medications were developed to treat severe mental illness like schizophrenia. Now, the psychogenic perspective, which basically looks at abnormal thought processes and the psychological factors that leads to mental illness, was investigated by both Frederick Mesmer and Sigmund Freud. So Frederick Mesmer used hypnosis to treat hysterical disorders, which were basically physical ailments that were thought to believe to be psychological in origin. And at the same time, Sigmund Freud was developing psychoanalysis, at the turn of the 20th century. And he was beginning the first formal outpatient psychotherapy sessions. Now, Freud did not agree with Mesmer, and Mesmer did not agree with Freud. Freud did not believe in hypnosis, although hypnosis is used currently today in certain settings, certain clinical settings. But Freud did not believe in it. Freud believed in, diagnosing through, dream analysis or through free association, where people basically just, have a stream of consciousness. They say whatever's on their mind, regardless of how logical or how appropriate it is. And so he believed that the unconscious could be brought to the conscious. And other projective tests that we'll talk about also are useful in psychoanalysis. But they disagreed on basically the role of accessing the unconscious. But they both believed that there was something psychological going on, whether it was the unconscious or repressed thoughts, etc., that was leading to psychological abnormalities. And as I was mentioning, Freud was the first to really stop hospitalization. So, we went from a bad situation with asylums, and then we moved into psychiatric hospitals after that, which were thought to be better than asylums because asylums were out of control. But psychiatric hospitals, even current psychiatric hospitals today, are not a place where a lot of healing takes place. I mean, the modern approach to psychiatric hospitalization right now is that the patient should spend the minimum amount of time there. You don't want to keep people in the hospital. You do not want to keep people in the hospital longer than they need to be kept there. Long-term hospitalization is never a goal. It might be the only thing possible with regard to someone with severe eating disorder, where they don't have the luxury to be outpatient because they might die from starvation. But even that's not the goal. The goal is to get people out of the hospital as soon as you can. And Freud started this outpatient psychotherapy. And people were going for psychoanalysis basically 3 days a week for years. And whether you agree with Freud's theories or not, his patients did improve. And they were kept out of the hospital many times. And this was the beginning of psychoanalysis and outpatient therapy, beginning of the 20th century. By the 1950s, psychotropic medications became popular. Antipsychotic drugs used to stop schizophrenia. So these drugs would suppress the hallucinations and the delusions, which were crippling to the schizophrenic. And as a result, hospitalization was no longer necessary. They were treated as an outpatient, although they had to take their medication, which is a problem even currently among schizophrenics. You also had antidepressant drugs. You had the development of the tricyclic antidepressants, which are still used today, although used much less than they used to be used in the past. And you had anti-anxiety drugs, primarily Valium, developed by Roche Pharmaceuticals, which is still probably the drug that saved Roche Pharmaceuticals. And Valium was extremely, extremely popular and abused for many, many years, if not decades. So much abused that you can't even get it today. That people will not prescribe Valium for almost anything. It's really hard to get, especially for anxiety, because of the abuse. So all these medications were positive. I mean, they all had numerous side effects, but they were positive in that it led to deinstitutionalization. So it led to people getting out of the hospital and into outpatient care. And if you look at the hospitalizations going from 1950 to the 2000s, it just basically dropped off tremendously. So from the 50s and 60s, you see tons of hospitalizations. Now, when the drugs came online in the 60s mainly, you had a huge drop off from 60s to the 70s, and then look at the 80s. You had a little bit of plateauing in the 80s to 90s, And it's kind of plateaued ever since. It's gone down a little bit more, but that huge drop off between 1960 and 1980, that's when the drugs came online and people were out of the hospital. And that was beneficial. Now, that doesn't mean they don't relapse and have to go back into the hospital, because they do often relapse. But minimizing the time in the hospital was thought to be better for the long-term prognosis. And if you talk to patients, they don't want to be in the hospital unless they absolutely have to be there. Most patients don't want to take their medication. They don't want to be in the hospital. It's a fine balance, especially for people with severe mental illness. It's a fine balance keeping them out of the hospital. They may have to be transported to long-term residential care. And you see this with substance abuse, drug addiction. People with severe drug addiction have to be treated in the hospital temporarily. They have to be tapered off of alcohol or other, recreational drugs. Slowly tapered in the hospital, and then they go to a long-term residential treatment center. And they're in that treatment center for months at a time, where they learn to self-regulate their emotions. They learn to not rely on alcohol or drugs as a coping mechanism. They receive therapy. They receive group therapy. In most of these places, there's a large number of substance abuse facilities in Florida. And that's where people are sent often, even from the Northeast. They're sent down to Florida to go to drug rehab. And they're in rehab for months, and then they get released to be on their own. And hopefully by that time, they've learned to avoid using the drugs or using alcohol, whatever they're using or abusing, as a way of coping, and they have better emotion regulation. They've gotten therapy for months at a time. So they're in a better position to, stay abstinent, because that would require long-term abstinence. They can't have, an alcoholic that's been institutionalized and been in rehab they cannot have a sip of any alcoholic beverage. They have to go to total abstinence, and in the case of opiate withdrawal, they may be given medication to deal with that. And eventually they may have to stay on that medication and slowly and very, very slowly taper it. But the bottom line is they're out of the hospital and they're out of the residential facility, and this is a good thing for them. It's not a good thing being in the hospital. If you've ever been in a psychiatric hospital, it's not a good place to be. You want to get out of there once you're stabilized. So outpatient or private psychotherapy has become the primary mode of treatment. Usually it's 1 day a week, although you can have intensive outpatient or IOP, which is multiple times a week. You might have outpatient therapy 3 times a week for a while, and then it gets tapered down to 2 times a week and then once a week. But most outpatients, among people that are not hospitalized, outpatient therapy is once a week. Can even be once every other week. It depends a lot of times on what insurance will pay for, but usually once a week they'll pay for. So this idea of getting them out of the hospital and into, either residential treatment or outpatient psychotherapy in community settings is helpful. The problem is that there's not enough of these outpatient treatment centers. And as a result, once people are discharged from the hospital, they don't get the help they need and they end up relapsing. So it's very important, if you work in a hospital, that you do discharge planning and that you have a really solid plan on how to get this person, what's called step down. Step down to a lower level of care and then step down again, gradually. Unfortunately, this discharge planning doesn't always work. People don't always follow it. They're lost in the, amongst the masses of people getting discharged. Some people fall through the cracks and they don't get the, step down treatments that they need, and they end up relapsing. And if it's medication, they may not take the medication that they need. And that's why it's important that they maybe step down to residential treatment to make sure that they're being monitored. You know, I've seen the schizophrenic patients in the hospital get discharged after a couple weeks with lots of medication to take at home, and then they refuse to take their medication, and then guess what? They're back in the hospital. And there was no discharge planning that was set up for them. There was a lack of contact with the patient, and the patient kind of ignored whatever phone calls were happening and ignored any treatment and said, okay, I don't want to take this medication. This medication makes me feel horribly, which it does. They stop taking it, they're back in the hospital. And it becomes a vicious cycle. And the families don't want to deal with it. Right? The family is tired of the cycle. They're tired of caring for the person with severe mental illness. That doesn't mean they're bad people. No, they love this person, but they're just tired. It's always happening. It's on and on and on. It's been going on for decades of getting worse in the hospital, getting better. The person refuses to take their medication. So you have to be really careful about how you discharge someone and how you follow up with them and make sure that they're taking their meds appropriately. Because compliance with medication is a huge issue in terms of treating mental illness. So outpatient care is on the rise. It has been since the development of psychotropic or pharmacological treatments for mental illness. And the amount of psychotherapy and the types of psychotherapy are more diverse now than they ever were before. So it used to be just one-on-one psychotherapy. Now you have group psychotherapy. You have psychotherapy in the community setting, I should say. You have, relationship therapy, family therapy, marital therapy. I mean, there's so many different modalities of outpatient care now that if you're at the appropriate spot that you need to be in terms of outpatient care, there should be improvement. But once again, and I hate to bring it up, it comes back to insurance. And having been on both sides of the issue with the insurance, it's very frustrating. What will the insurance pay for? And it's important because people don't have the money to be paying out of pocket for outpatient psychiatric care because it can become very expensive. So what does your insurance company cover? Do they cover the residential treatment? How much of the residential treatment do they cover? That's going to affect how long you're going to be there. That's going to affect how you're going to be in the long term, especially if you don't have money to pay for it. In the low-income communities, you're going to see lots of people with mental health problems who are untreated because they don't have the money, they don't have insurance, they don't have a outpatient clinic to go to because it costs too much money. It's nice to say to the providers, why don't you offer up some of your practice to people that are relatively poor that need treatment? And so maybe take $20, $15 from them. Well, if you're a practitioner, do you want to take $15? Do you want to take Medicaid? Right? Medicaid is the state-provided health insurance for people that have low income. If you're a provider, do you want to take Medicaid, which will only reimburse you $20 or $30? Versus, would you rather give that spot to someone that can pay out of pocket or that has insurance that'll reimburse you $150? So, and if you do take the Medicaid slot, right, you take a few slots from Medicaid, how much can you provide? I mean, how many hours can you give where you're going to be reimbursed $20 by the state? Can you be doing that all the time? Because if you're a practitioner, it's not that you don't want to do it. Of course you do. You want to help all kinds of people. But you also have to pay rent for your office. And it's not cheap. You also have to pay for malpractice insurance. So there's overhead. You have to pay for advertising, marketing. I mean, there's lots of costs involved. You may have to pay for staff if you have a lot of patients to run your office. And so then how many of those Medicaid people can you really accept if you have all these other expenses? And that's why, even though there's a large variety of settings in which you can receive outpatient therapy, that's true. There's a lot more settings that you can receive the therapy than there was in the past. Even though that's the case, how much, you know, how many people are going to fall through the cracks of the system? And the answer is lots of people. There's lots of people that don't have money that are going to fall through the cracks. And they're not going to get the treatment they need. They're not getting the medical coverage they need either. And so we need to find a better way to address this problem. You know, can Medicaid pay more for psychiatric conditions? I mean, there are parity laws that state that mental health should be reimbursed at similar levels to medical problems. But the problem with Medicaid is they pay $20 or $30 to the physician too, to a primary care physician. But it's different with a primary care physician. The primary care physician sees a patient for maybe 5 minutes and gets paid $20 or $30. And that's more tolerable. If you're a psychotherapist, you're seeing a patient for 45 or 50 minutes and being reimbursed $20. So the cost is a major issue in terms of treatment, and there has to be a better way to treat people that cannot afford the normal price of psychotherapy, because it can be very expensive. And some therapists won't take any insurance, and they're going to set their price at $200 or $250, and they'll take no insurance. And you see, there's an issue. I mean, if you're the therapist, you want to get paid too. So I'm not blaming people for wanting to get paid to make a living, but how can we serve the entire community given the situation with the insurance or with Medicaid and with Medicare? Medicare pays more, but they don't pay that well, but they pay a lot better than Medicaid. Medicaid is really the issue. They don't pay enough. As I was mentioning, we have a wide variety of different outpatient treatments. We also have multicultural psychologists, and they're going to look at factors like culture, race, gender, ethnicity, and how they play a role in behavior. And you see a lot of cultural factors. And if you're a therapist and you're unfamiliar with cultural factors, it's going to be more difficult treating the client. So if a client believes something and has maybe a maladaptive cognition, sort of an illogical thought pattern, based on their culture or based on their religion or based on something else that's long-standing and hard to change, if you don't identify those cultural issues and work within that cultural framework, the treatment is not going to be very successful. So as a clinician, you have to understand people from a wide variety of perspectives. And they may not be of the same culture as you are, but you have to be able to understand and relate to different cultures. And that's challenging. And that requires experience. That's not something that you're going to read a book and just get. That requires a lot of experience. And with experience treating a diverse group of clients, you're going to be able to adapt to people's, individuals' situations better and make better decisions based on race, culture, gender, etc. So unfortunately, I have to go back to the insurance issue. Unfortunately, insurance plays a large role in treatment of mental health. I wish it didn't, but it does. And having worked for the insurance companies, I used to work for Magellan Healthcare, that was determined to approve or deny different types of treatment, and it's really brutal. to work in a situation where you're denying people that need therapy, the treatment that they need. So the problem is the low reimbursement rates. If you don't have good insurance, or especially if you have Medicaid, as I said before, you're not getting paid well. It's not paying enough to the clinician, and the clinician's not going to want to take you. So I've been on a situation where my team had to deny people admission to the hospital for inpatient therapy that they needed. We thought they needed, and the patient's clinician thought they needed, and they submitted the request to the insurance company, and we denied it. And we said, no, you don't need to be put in the hospital. You can have intensive outpatient, so you can be treated as an outpatient. When in the situation it really called for them to be hospitalized, they didn't want to pay for it because it was too expensive. And the problem with the insurance company is the less they spend on treatment, the more profit they make. So there's an incentive to keep things costing as low as possible. I've seen it with the eating disorder clients who were in the hospital for months at a time, inpatient psychiatric hospital. They refused to eat. They were being fed intravenously. And I had meetings with the vice presidents of the company, and they were asking me questions along the lines of, how do we lower the cost for this inpatient treatment of eating disorders? Because the patients are in the hospital for many months at a time sometimes, because they are that close to dying. And I would bring up the point that, we can try a different intervention, get them the therapeutic help they need while they're in the hospital, and gradually taper them off of the intravenous feedings. Start gradually weaning them off of it, getting to increase their caloric content slowly, because they had severe anorexia and they refused to eat anything. And that this process is going to take several weeks at least. Well, that's not going to really work for the VPs that are in charge of making these decisions, right? The several weeks is too much money to spend. So their reasoning is, the person has been in the hospital, several months already. There are some cases where an eating disorder patient is going to die no matter what we do. That was their reasoning. That a certain percentage of eating disorder patients are going to die no matter what the treatment is. And therefore, we need to discharge them. So that's what you're dealing with that perspective. That they're willing to let people die to save them money. Because no matter what I do, or no matter what we do as a company, as far as approving treatments, a certain percentage of people with anorexia are going to die. It's a big problem. It's one of the reasons why I needed to get out of there. I couldn't work, even though I wasn't making these decisions directly. The fact that I was involved with a team of people making these decisions, mainly through analyzing data and looking at profits, right? Because they wanted to look at the money they make every day, which is crazy. They're looking at profits every single day and how the decision affects their bottom line. And we're talking about the VPs are not just business people. The VPs are psychiatrists. The VPs are clinicians. So I wasn't dealing with just business people. You're dealing with mental health practitioners that are elevated to high positions within the company making these decisions, profit-based decisions. And it's difficult to deal with. And so I was happy to get out of there. When I got my job at BMCC, I needed to get out of there because the people I worked with on my team were great. And I liked it personally. I just couldn't understand the decisions from corporate about how to deny people. It was just very troubling. Now, in terms of different areas of psychology, in terms of treating mentally ill people, there's a variety of perspectives. You have psychoanalytic, You have the biological, which is mainly pharmacological treatments. You have cognitive and behavioral, which are often combined into cognitive behavioral therapy or CBT. You have humanistic existential, and you have the social cultural perspectives. These are the major perspectives. I would say out of these, cognitive behavioral is very big. Obviously, pharmacological or biological is huge. And you still have a pretty strong psychoanalytic slice, there, especially in New York City. There's a lot of psychoanalysts. Humanistic existential is kind of dwarfed. There's not too many people practicing that. That's a Carl Rogers approach. Right? Social cultural would be someone that's focusing on environmental cues. So these people are mainly sociologists that would look at what is society's influence on mental health. And that's important too, but they're not directly involved in treatment per se. Profiles of mental health practitioners in the US, you have psychiatrists that have MD degrees, they're medical doctors, or they have a DO, a doctor in osteopathic medicine. And they can make up to hundreds of thousands, if not more, money. So they basically make the most money. If you care about money, they make the most money. They can be really well paid at some of the bigger hospitals. And they are predominantly male, although 1 out of 4 is female. But you have to go to medical school. And then you have to do your residency. You might have to do an additional internship. So there's a lot involved with that. And you're working mainly out of the hospitals. Psychologists have PhDs, PsyDs, or EDDs. PhD is a research degree, so a psychologist with a PhD is interested in doing research, usually at a university. So I have my PhD. I'm interested in doing clinical and health-related research. I am not really interested in practice. I want to do research, especially health-related stuff. So why do people get depression? Why do people get somatization? How do I treat people with somatization? So that's my main area is, how do I do interventions, developing interventions for somatization. And we're looking at things like hypnosis. Not hypnosis, I'm sorry. We're looking at things like meditation, I should say. Meditation, we're looking at binaural beats. We're looking at journaling. We're looking at a variety of interventions in terms of improving people's clinical status. Non-pharmacological interventions we're doing. If you have a PsyD, you're not doing research, you're mostly doing clinical practice, but that's considered a doctorate. Those people don't have to do a dissertation per se. People that do a PhD have to write a dissertation. And EDD is a doctorate in education, so their degrees in the education field. You don't see that as much. You may see a psychologist with an EDD practicing, but you don't see them as much doing research. And obviously psychologists make less money. It depends on where you live, depends on your job, but you can make significantly less money, especially if you start. And you have to generate clients. So if you're practicing and you're not doing research, you need to get patients or clients. Patients if you're a psychoanalyst, clients if you're not. Where do you get those clients from? How much are you going to charge them? How do you keep them? What's the turnover of clients? So that's a big deal. So there's a lot of marketing involved there. There's flexibility, like sliding scale, where you can take different amounts of money. Do you take insurance? Do you not take insurance? A bunch of decisions there. Social workers can work in a variety of areas. They can work for government. They can work for the state. They can be caseworkers where they're visiting houses and dealing with particular situations like domestic abuse or childcare, adoptions, all kinds of issues. Or they can be clinical social workers where they're doing basically the same thing that a clinical psychologist would do. So whether you're a licensed clinical social worker or LCSW, you can have your own practice. And you're basically the same, you're doing the same thing. A clinician is a clinician. Whether you're a social worker or whether you're a psychologist, it doesn't matter. If you're a clinician, you're doing clinical work. DSW is a doctor in social work. So these people are either working at the university or they're in practice, or maybe they're working as the head of a nonprofit organization. That's another option. And then the pay, like you see the pay here, the pay is all over the place. I mean, these numbers are kind of low, on the low end, especially in the New York area. You're going to see things much higher. Cost of living is higher and the pay is generally higher. But it depends on experience. Starting out, you're not going to make a lot of money starting out. I think pretty much any field, except if you're a psychiatrist. If you're a psychiatrist, you're going to make good money starting out. But if you're a psychologist, a social worker, or a counselor, you're not going to make that good money starting out. You're going to make enough money. I'm not saying you're not going to be able to live on it, but you're not going to make a tremendous amount of money starting out. And then with experience and with promotions and all that, with more clients, etc., you can make more money over time. And you can do quite well. I mean, one of the real positive aspects of counseling these days, I mean, the aspect that's getting a lot of growth is the family therapy, marital and family therapy. If you're a good marital and family therapist, whether you're a clinical social worker or a psychologist, it doesn't matter what you are. If you're good at family and marital therapy, you can make tons of money because you'll be in demand. You'll be able to charge what you want because people will pay a lot of money to save their marriage. They'll pay a lot of money to deal with children they can't deal with, that they're having severe problems with. When it comes to family, people are invested. There's no money that's going to stand in the way of people fixing their marriage, their family life. I'm not saying you're going to rip people off. What I'm saying is you can charge them $200 an hour, $250 an hour out of pocket without insurance, and people will pay that to save their marriage. Even people without money will pay a lot of money to save their marriage because they're invested, obviously. I mean, if you're in a relationship or you're in a marriage for a long period of time, you just don't want to throw it away. You're going to do everything you can in most cases to save it. So that's an area if you're good at that. And I'm not saying everyone's good at that. Some people are better than others at dealing with marital and family problems. But if you're talented and you have success helping people in this area, you are going to be successful financially as a therapist. And you have the potential to make more money than if you're just doing individual therapy with people that are, I've been dealing with a lot of stress, I have a little bit of anxiety. Those are more common problems, but you're not likely to have the great demand in those areas. So that's just my observation, knowing people that have done marital and family therapy and how successful they are. Counselors, these are people that work in schools or universities, mostly doing therapy. They tend to make a little bit on the lower end compared to psychologists that have their own practice, because obviously they're getting paid salary, they're not getting paid per client. And you see a large portion of clinicians in general are female. Especially if you look at social workers and counselors, the rate's even higher. Now, a lot of people ask about career advice. Do you need to do the PhD or the PsyD? You don't need to do that to be a clinician, to be a therapist. You can do a 2-year master's program, like a master's in social work, and then you do your clinical hours. You have to do several thousand clinical hours. Usually it's 2,000 to 3,000. It depends on the state where you're going to get licensed. That means you're working underneath somebody else and you're getting supervision from someone that's already certified. So you're working for someone else. You're doing therapy, but you're underneath somebody. You have a supervisor. And that's going to take several years. But that's fine because you're still getting paid and you're getting experience. And once you do your clinical hours, after several years of that, you get your license. So you have your licensed clinical social worker, and you can have your own practice. And then you can charge whatever you want and have as many clients as you want. So there's no real need to get a PhD or even a PsyD. I mean, if you want to work at a university, you need a PhD. So for me, I want to work at a university. I didn't want to do therapy because I wanted to do research. I wanted to teach my courses. I was into that sort of thing. The therapy domain was going to be very challenging for me. I didn't think I wanted to do that full time, but everybody's different. Some people love doing therapy. And you can get by being a good therapist, being well compensated with just your MSW and then the several thousand hours of supervision to get your clinical license. And you can have your own practice, and you'll be doing basically the same thing. You just won't have a PhD. So if the PhD is important, that's one thing, but you're going to be going to school took me 6 years. And you're going to be under a lot of pressure, and you'll be doing a lot of research. Versus a social work degree, which will take you 2 years. So there's viable careers with just a 2-year degree. That's basically what I'm saying. It's not really worth it going for 5 or 6 years if you don't need to. And this ties in with the other point, is that clinical practice and research go together. You need both. You need people to practice and you need people to do research. Personally, I am one that likes to do research. You might be one person that wants to practice. So the results of my research are going to feed into your practice. They complement each other. Ideas have to be tested. Different therapeutic techniques have to be tested doing your research before you want to use them in a clinical setting. And I think that's important to note that everything is going together. It's just like drugs and vaccines, that you have to do the medical research before you can treat the patient. So if you're into research and you want to do clinical research, which I like doing health clinical/clinical research, then do the PhD. But if you want to treat patients and do therapy, then the LCSW, or if you wanted to do a more involved program, you could do the PsyD, which is a doctorate in psychology, but it's mostly clinical. There's even a doctorate in counseling it's mostly clinical, less emphasis on research. And last but not least, technology and mental health. We know that technology is playing a huge role. We really know this now in treating mental health. Skype, Zoom, YouTube Live, Instagram Live, whatever. Therapy is being conducted on all these clients, in all these modalities. Mental health apps have skyrocketed. Well, we need them because, we can't always be face to face with our therapists. Sometimes it's not possible. So we need to have increase in cyber therapy. Is it as effective as regular therapy? People are getting good results with cyber therapy. It's hard to really compare. You would have to have a randomized design with a control group. It's hard to do that. You can't just tell people do cyber therapy or don't do cyber therapy. It's kind of hard to run that kind of study. But people are having good results with cyber therapy, and I think it's going to continue, and it's going to get better. Whether it's through virtual reality, and there's lots of virtual reality stuff out there too, if you're into virtual reality. There's virtual reality treatments for phobias, for anxiety. disorders, where you basically go onto some sort of virtual experience, and it's almost like playing a game, and you're trying to induce your body to relax. So it's kind of a neurofeedback program. I've seen them. I've done them also, these programs in virtual reality. I've actually used them, and they're really interesting. And I think that if VR is making, it's progressing. It's kind of been an abstract concept, this whole idea of virtual reality. People are like, oh, it's not going anywhere. I think it is going somewhere. I think it's going to get better and better. It's obviously got better over the last few years, and it's becoming more affordable. Now, the big clinical rigs for people that have anxiety disorders and phobias, those are more expensive because those are more involved. Those aren't cheap that you can just go get it online. It may cost thousands of dollars for a clinician to have, but VR is becoming more accessible to the general public, and the therapy within the VR environment, I think, is going to become more effective. So if you have a phobia of heights and you can't physically climb up to the top of a huge building, you can then do that in VR. Or if you have a phobia of flying and you don't want to get into a plane, or maybe you don't have the money to pay to just get into the plane just to try to desensitize, your phobia, you could do that treatment in VR where you feel like you're getting into a plane. And some of these VR apps are so complex that you can look around in them. So they have, I think, 6 degrees of movement. So you can walk around in the VR environment. You can look up and you can look down. You can look down like you're standing on top of a skyscraper and look down. And that's going to be anxiety provoking, but that's what you need to treat a phobia, especially a phobia of heights. So there's some promise with VR applications and therapy, and cybertherapy in general is being used all the time, and it's pretty effective. It's more effective than I thought it would be when it first came out. It's pretty effective doing Skype, Zoom, FaceTime, whatever other approaches there are. There's a whole bunch of them. And that's about it for Chapter 1. Hope you enjoyed, and I'll see you in class for Chapter 2, which is on research design. Bye for now.